Okay, it's polymyalgia rheumatica. Can you hear me?
Yes.
This patient has polymyalgia rheumatica, an inflammatory disorder characterized by following feature: acute onset symptoms 2 weeks at age more than 50, prolonged morning stiffness with inactivity and in proximal joints, systemic symptoms, fever, weight loss, markedly elevated inflammatory markers, ESR, CRP. PMR involves periarticular structure bursa tendon, but the muscle itself unaffected and histologically where I am reading. I lost. Okay, and histologically normal. Sorry. Therefore, objective muscle strength is preserved as in this patient, although range of motion can be limited due to pain and stiffness. There is no specific test for PMR. Treatment with low dose glucocorticoid therapy 20 milligram daily. In case usually initiated in patients with a characteristics presentation, a rapid sequence support the diagnosis where lack of improvement should prompt consideration of other diagnosis. These patients these patients presentation and rapid symptom improvement with prednisolone are sufficient to establish the diagnosis of the PMR. No additional testing is required. Okay. Is it polymyositis? Proximal muscle weakness. Probably. Polymyositis is an inflammatory muscle disease that presents with slowly progressive proximal muscle weakness of the lower extremity. difficulty negotiating stairs or rising from seated position. Proximal arm weakness usually follows, leading to difficulty working with arms overhead. Patients may develop dysphagia due to involvement of the striated muscles of the upper pharynx. Mild pain or tenderness can develop due to inflammation. However, significant pain or lack of weakness should prompt consideration of other diagnoses. Polymyositis is similar to dermatomyositis, but without skin finding. Muscle enzyme CK are invariably elevated. An autoantibody, anti-nuclear antibody, anti-Jo1 antibody present in most cases. A muscle biopsy is most definitive diagnostic test and show a mononuclear infiltrate. Is a mononuclear infiltrate surrounding necrotic and regenerating muscle fiber. Okay. Is it rheumatoid arthritis? It is felty. This patient with a swollen, deformed hand joints and elevated ESR likely has untreated, likely has in untreated inflammatory polyarthritis. The presence of concurrent neutropenia and splenomegaly raises strong suspicion for Pilti syndrome. An uncommon but serious complication of long-standing erosive rheumatoid arthritis syndrome is marked by formation of the autoantibody against the neutrophil component and granulocyte colony stimulating factor leading to neutropenia. Absolute neutrophil count less than 2000 are increased risk of recurrent bacterial infection, particularly of the skin and the sinuses. Neutrophil coated with antibody also trapped in the spleen, are also trapped in the spleen, which usually results in splenomegaly. Most patients have extraarticular manifestations of RA, such as lymphadenopathy, rheumatoid nodule, and or necrotizing lesion. The diagnosis is made based on clinical feature but is supported by the presence of high titer rheumatoid factor anti-CCP antibody, both of which are usually elevated in RA. Most patients also HLA-DR positive, indicating genetic susceptibility, and other causes of neutropenia should be ruled out with bone marrow biopsy and peripheral smear or to establishing the diagnosis. Symptoms generally improve with treatment of the underlying RA. Next, Okay, look at the post-amputation pain box. Post-amputation pain, acute stump pain, tissue and nerve injury, severe pain lasting 1 to 3 weeks, ischemic pain, swelling, skin discoloration, wound breakdown, decreased transcutaneous oxygen tension, post-traumatic neuroma, mm, post-traumatic neuroma weeks to months after amputation, focal tenderness after local sensation, decreased pain or with anesthetic injection, phantom limb pain, onset usually within 1 week, increased risk in patients with severe acute pain, intermittent cramping, burning felt in distal limb. This patient has intermittent this patient has intermittent stump pain despite good wound healing following lower extremity amputation. The pain is elicited by focal palpation near the operative site, which suggests a post-traumatic neuroma. Post-traumatic neuroma are initiated by transection of the nerve fibers, which leads to inflammatory reaction and formation of a tangled mass of unmyelinated nerve fibers. These nerve endings have decreased depolarization threshold that cause pain signals spontaneously or in response to non-painful stimuli. Post-traumatic neuroma from over several weeks to months following injury or amputation because the pain is worsened by local pressure. Neuroma can complicate fittings for prosthetic devices. The diagnosis is based primarily on clinical grounds, but injection of a local anesthetic can provide transient pain relief and confirm the diagnosis. Management typically involves excision of the neuroma. TCA and anti-epileptic medication can be used for pain management prior to surgical intervention. Yes, heterotropic ossification is characterized by abnormal soft tissue calcification. It is common in traumatic amputation. It is common in traumatic amputation in which the amputation line passes through a regional damaged tissue than in surgical amputation. Common associated findings include swelling, erythema, fever, and skin ulceration. Stump hematoma typically presents with swelling, ecchymosis, skin breakdown in the first several days following amputation. Formation of a chronic expanding hematoma may occur, but is rare, would not cause point tenderness with only minor soft tissue swelling.
No, 65.
Hematocloto of long time diabetes. So it may be diabetic problem. Okay, look at the picture. Hello, can you hear me? Okay. Is there any way of remembering like hemato and the cloto, like which is the dorsal, which is the okay in hemato dorsal flexion of the DIP and dorsal flexion of the MTP joint, dorsal flexion MTP joint, and in cloto there is dorsal flexion of the MTP and plantar flexion of PIP, plantar flexion of the PIP and DIP joint, plantar dorsal flexion DIP. Okay, this patient has, sorry, yes, in hammer 2, like plantar flex, dorsal flexion of the DIP and in cloto plantar flexion of the DIP. Oh, dorsal deviation. Okay. This patient has cloto deformity characterized by dorsiflexion at the metacarpophalangeal joint and plantar flexion at proximal and distal interphalangeal joint. Cloto and hammerto similar to cloto but with dorsiflexion at the distal interphalangeal joint. Deformities are common in elderly patient and reflect an imbalance in strength and flexibility between the flexor and extensor muscle group. These deformities are often due to simple mechanical problems such as chronic ill-fitting shoes, but in patients with long-standing diabetes, they may suggest underlying diabetic neuropathy. The etiology of the foot deformity in patients with diabetic neuropathy involves multiple factors, including atrophy of the intrinsic foot muscle due to degeneration of the motor axons, decreased pain sensation and proprioception, and concurrent orthopedic and vascular disorder. Long-term complications of diabetic neuropathy include callousing, ulceration, joint subluxation, and charcot arthropathy, bone and soft tissue destruction and deformity. Okay. Sorry, chlorothalidone. Yes, as a diuretics. Yes, hypergluc. Uh, the mnemonic is hypergluc. The side effect of thiazide is hypergluc. This is Paget's disease, isn't it? Because he has hearing problem. He also had a hearing aid recently acquired. 60 years old man, hearing problem, hearing loss. So is it osteoclast dysfunction? This patient with bone pain, this patient with bone pain, headache, unilateral hearing loss, femoral bowing. This patient with bone pain, headache, unilateral hearing loss, and femoral bowing has typical symptoms of the Paget's disease of the bone. Paget's disease is most common disorder after osteoporosis, affecting approximately 3% of adult age more than 40. It is characterized by focal increase in bone turnover, focal increase in bone turnover in which osteoclast dysfunction leads to bone breakdown and a compensatory increase in bone formation. The pelvis, skull, spine, and long bones are most commonly involved. Microscopic findings include number microscopic findings include increased numbers of abnormal appearing osteoclast, increased number of abnormal appearing osteoclast with a disorganized mosaic pattern of lamellar bone. Disorganized mosaic pattern of lamellar bone. Early, early stage lesion will have a predominance of osteoclast activity, later progressing through a mixed osteoblastic phase, a predominantly osteoblastic phase, and a residual sclerotic phase. Most patients with Paget's disease are asymptomatic and are identified incidentally by radiographic findings or elevated ALP. Symptoms may include skeletal deformity, bone or joint pain, fracture. Enlarging cranial bones may lead to increased head size, headache, hearing loss due to entrapment of cranial nerve 8 or encroachment on the cochlea. Additional complications include benign giant cell tumor of the bone and osteosarcoma. Okay, maybe, probably. Why? Diagnostic aspiration is done if there is, like, if any fluid is located, like for septic arteries, for other form of arteries.
Yes. Was it the answer?
Pace answerness bursitis. This patient has pace answerness bursitis related to overuse. The answerness bursa is located. The anserine bursa is located over the medial tibial condyle. The anserine bursa is located over the medial tibial condyle, distal to the joint line, and deep to the pace answerness tendon complex. Repetitive friction. Repetitive friction exacerbated by mechanical derangement of the knees, medial meniscus protrusion, medial collateral ligament displacement, and obesity is thought to cause bursal fluid. Pey-Sansonis bursitis is a part of broader syndrome, Pey-Sansonis pain syndrome, that also includes non-bursal cause of the upper medial tibial pain. Initial management include rest, NSAIDs, to enhance the fitness and address the mechanical derangement. Patients should also perform exercise that increase the strength, flexibility of the quadriceps and hamstring, which stabilize the knee. Weakness and tightness in this muscle increase the stress of the articular bone, ligament, cartilage, and periarticular bursa and tendon tissue. An imbalance between those opposing muscle, quadriceps stronger than hamstring muscle, can lead to injury to the weaker muscle and tendon, and where stronger muscle contracts. Okay, okay. When redness and warmth, when redness, warmth, and severe tenderness accompany the bursal fluid, uh, accom- when redness, warmth, and severe tenderness accompany the bursal swelling, and aspiration, an aspiration should be done to rule out the septic bursitis. This patient does not have this acute inflammatory change. Okay, redness, warmth, and severe bursal. And MRI to look for ligament or meniscal tear, which typically presents with significant knee pain and effusion following trauma. Stress fracture can be missed by X-ray and can be diagnosed with MRI. Stress fracture MRI, especially in early stages of 1 to 2 weeks. These patient has had symptoms for 3 weeks. Stress fracture significant enough to cause localized swelling and would have been identified on X-ray. Okay, can you give me 5 minutes? I have an important call. Okay, okay. Okay, how you diagnose this? Mm, yes, and transient synovitis age group is 3 to 8. Fat, yes, yes. This obese patient, this obese patient with uh, this obese patient with dull thigh pain, and decreased range of motion of the hip likely has slip capital femoral epiphysis. Slip capital femoral epiphysis occurs when excessive shearing at the proximal femoral epiphysis growth plate weakens growth plate weakens the growth plate, causing anterior-posterior displacement of the proximal femoral diaphysis and giving the appearance of posteriorly displaced femoral head, causing anterior-superior displacement of the proximal femur, causing the anterior-superior displacement of proximal femur. Obese adolescents are at high risk due to increased mechanical strain of the hip. Symptoms most commonly include chronic more than 3 weeks intermittent dull pain or ache of the hip, thigh, or knee that is exacerbated by activity as seen in this patient. The leg is typically externally rotated, foot pointed laterally, and the gait may be altered due to pain. On examination, decreased range of motion, particularly internal rotation and tenderness of the hip may be present. Abduction or external rotation of the thigh during passive flexion of the hip is characteristic. Diagnosis is confirmed by diagnosis is confirmed by visualization of the posteriorly slipped femoral head on X-ray. Okay.
Right next to it, but no pain.
Yes. Yes. Okay. This patient likely has GIA, a chronic inflammatory condition of the childhood. Oligoarticular GIA, the most common form, is characterized by involvement four or less than four joint, less than four or less than four joint, that is less than five joint, within the first 6 months of the disease. A limp that is worse in the morning, a limp that is worse in the morning in a toddler girl, age less than five, such as in this patient, is a typical presentation of oligoarticular GI. Joint swelling is present, joint swelling is present, but pain may be minimal. The large joint, knee, ankle are most commonly affected. However, hip involvement is rare. Systemic symptoms, fever, rash do not occur. Uveitis is a strong uveitis is a serious complication that develops in a minority of the patient with oligoarticular GI. Ophthalmologic screening examination are performed regularly because untreated uveitis is often asymptomatic and can lead to irreversible vision loss. Although not present in all patients with oligoarticular GA, antinuclear antibody are the risk factor for uveitis. Additional lab findings, leukocyte count, hemoglobin, erythrocyte rate are typically normal in oligoarticular GA. Treatment is aimed at relieving inflammation and include NSAIDs, intra-articular glucocorticoid, and disease-modifying anti-rheumatic drugs. Yes, Is it DDH?
No.
Okay, it's septic arteries. This patient, there was fever, but I completely ignored the fever.
The fever.
This patient had fever, pain with head movement, and leukocytosis. Pain, fever, pain with hip movement, and leukocytosis, septic arthritis. This joint infection most commonly occurs in healthy children aged less than 4 by hematogenous spread of the bacteria. Staph aureus is the most common pathogen, but group B and gram-negative bacilli, Klebsiella, E. coli are E. coli also occur frequently in infants aged less than 3 months. The presentation is classically include acute onset fever, monoarticular joint pain, and inability to bear weight in infants. Symptoms may be asymptomatic, including fever, inconsolability, poor feeding, as in this patient, subtle signs of joint involvement, most commonly knee and hip, and in infants, lack of movement of the affected side. Pseudo-paralysis, lack of movement of the affected side, and excessive fuzziness during diaper changes and repositioning, as seen in this patient. Infants often lie with affected hip. Infants often lie with affected hip flexed, abducted, and externally rotated. Flexed, abducted, and externally rotated to maximize joint space. Physical examination may reveal pain with active and passive motion as well as asymmetric swelling. Supportive findings include leukocytosis with neutrophilic predominance and elevated inflammatory markers, C-reactive protein ESR. Management include joint aspiration and prompt initiation of the antibiotic. Okay, okay, it is fracture neck femur. Look at the shortened femoral neck. There is cortical condylar disruption and impacted fracture. This patient experienced an unwitnessed fall resulting in a left femoral neck fracture. Most hip fracture require surgical fixation, and the specific intervention required total hip arthroplasty. Intermedullary nail depends on the exact location and details of the individual case. In medical stable patient, surgical repair should be surgical repair should be performed as soon as feasible, typically within 24 hours, to relieve pain, minimize complication, and reduce the length of hospital stay. However, in patients with unstable medical conditions such as this one, surgery may be temporarily delayed to perform a more extensive preoperative evaluation. This patient's inability to recall the circumstances of his fall and his uncertainty about whether he lost consciousness and raised suspension for syncopal episode. His tachycardia and palpitation may be due to arrhythmia. Decreased breath sounds on the right side could be Decreased breath sounds on the right side could be due to pleural effusion and cough, dyspnea, and left basilar crackles also suggest pulmonary edema and pneumonia. These mm, the patient should therefore evaluated with electrocardiography, cardiac marker, and chest X-ray, like echocardiography, to determine the etiology of his fall and assess his preoperative risk factor to surgical correction of his fracture and acute heart failure and unstable arrhythmia, and consider high-risk fracture warranting further workup. Once his medical condition is diagnosed and optimized diagnosis for heart failure, he may be cleared for surgical intervention. A delay of the surgery more than 72 hours should be avoided when possible, because this has been associated with increased morbidity. It's lateral epicondylitis. This patient has subacute lateral elbow pain reproduced by resistant contraction of the wrist extensor, finding consistent with lateral epicondylitis. Lateral epicondylitis, sometimes referred to as lateral elbow tendinopathy. Lateral epicondylitis is classically seen in tennis players due to repetitive backhand strikes tennis elbow, and may occur with the use of hand pulls, as in this patient, and other overuse of the wrist extensors. Although the name implies an inflammatory process, lateral epicondylitis is lateral epicondylitis is more accurately characterized by angiofibroblastic tendinosis, disorganized tissue, and nerve vessels. Uh, although the name implies an inflammatory process, lateral epicondylitis is more accurately characterized by an lateral epicondylitis primarily affects the conjoint tendon of the extensor carpi radialis brevis and extensor carpi radialis brevis and extensor digitorum at the lateral epicondyle. Extensor carpi radialis brevis, common extensor tendon. Okay. Okay, lateral epicondylitis affects the conjoint tendon of the extensor carpi radialis brevis and extensor digitorum and the lateral epicondyle of the humerus. Maximal pain and tenderness are typically seen approximately 1 centimeter distal to the lateral epicondyle, and the pain may be reproduced by passive wrist hyperflexion, wrist and wrist extension, or making a fist grip strength testing, all of which transmit force through the uh, through the affected tendons. The diagnosis is made clinically. Initial management involves activity modification and the use of counterforce, elbow brace, tendinosis strap. The brace is applied just distal to the elbow and reducing the load of the transmitted to the tendon origin. Some patients prefer a compression sleeve. Okay. I start clicking over your screen. Okay. This patient with chronic skeletal pain, this patient with chronic skeletal pain, patches of the bone, a common disorder in younger adults, common disorder in, older adults, as is of the bone is characterized by abnormal osteoclastic activity that leads to increased bone turnover and disordered bone remodeling. Evaluation often shows elevated serum alkaline phosphatase level, reducing new bone formation, often with thickening of the cortical and trabecular bone, and either osteoclastic or mixed lytic sclerotic lesion visible on X-ray. Bone turnover in a phagetic lesion causes increased radiotracer uptake on skeletal scintigraphy, often with a multifocal pattern. Patients with patches of the bone can develop complication due to focal enlargement, weakness, or fracture of the bone, bowing of the long bones, bone pain, and arthritis in adjacent joint are common. Vertebral lesion can cause radiculopathy. Vertebral lesion can cause radiculopathy or spinal stenosis. Involvement of the cranial bones. Involvement of the cranial bones, as indicated by increased radiotracer uptake in this patient may cause frontal bruising, increased head size, headache, and cranial nerve pulses. Hearing loss may occur due to enlargement of temporal bone encroaching on the cochlea. Okay. Yes. Pulmonary metastasis can be seen in a variety of the malignancy, most notably colorectal, breast, gastric, and bladder cancer, as well as melanoma. Although lytic phase phagetic lesion may resemble malignancy, particle thickening and eccentric trabecula are diagnostic of the PDB.
Yeah.
Okay, this patient has subacute. This patient has subacute leg pain consistent with tibial stress fracture, which is which most commonly occurs in athlete, runners, dancer, and other individual who increase their activity level without adequate rest. This type these type of fractures caused by repeated tension or compression and absent recovery periods. They are especially common in women who have low caloric intake and functional hypothalamic amenorrhea, which lowers the bone density, low BMI. Other factors contributing the stress fracture include improper footwear, biochemical abnormality, weak calf muscle, high arch foot, weak calf muscle, high arch foot, inadequate calcium and vitamin intake. In addition to the tibia, stress fracture can be seen in the metatarsal, tarsals, and navicular calcaneus, and less commonly the femur and the pelvis. Diagnosis is based primarily on clinical factors including localized activity-related pain and point tenderness on palpation. Swelling may be present. X-ray is frequently normal, especially in the first few weeks, but may reveal periosteal reaction at the fracture site. MRI and bone scan are more sensitive but usually unnecessary unless a high risk site is involved. Okay.
Can you recall the other?
Yes, chronic exertional compartmental syndrome. Chronic exertional compartmental syndrome is characterized by increased pressure within a muscle group during exercise. Increased pressure within a muscle group during exercise. It is typically seen in young long distance runner, military recruits, and with presenting with lower leg muscle pain that consistently appear during exercise and resolve within 20 minutes of stopping the activity. The pain is regional and occurs along the muscles and is not associated with resting point tenderness of the bone. Injury to the interosseous ligament, high ankle sprain, presence with acute anterolateral uh, acute anterolateral ankle pain, typically following rotational force on a dorsiflexed knee. Patient on a dorsiflexed knee, patients frequently have associated fibular fracture. Medial tibial stress syndrome, shin splint can cause anterior leg pain resembling of the stress fracture. It is usually seen in or overweight or novice runners and is characterized by diffuse painful area rather than point tenderness along the shaft of the tibia. Antibial anterior tendinopathy. Tibial anterior tendinopathy is characterized by more diffuse area of the pain along the anterior aspect of the tibia that worsens with resistant dorsiflexion. This chronic overuse injury is common in long distance or older runner and bicyclists who do a lot of hill training. Okay.
22-year-old person 6.
What is the diagnosis? Oh, they already told you the diagnosis. Anti-U1 RNP is positive in which? This is the classic. MCTD, mixed connective tissue disease. And in mixed connective tissue disease, lots of diseases are mixed here. So, no, no, wait. And ANA is positive. So, in mixed connective tissue disease, there is SLE, isn't it? Okay, one. He has SLE, mixed connective tissue disease, lots of disease. The skin and hands are shiny and thick. So, there is systemic sclerosis, isn't it? Two things present. Okay. Oh, okay. There are other thing like look at he has exposed to cold and frequent episode getting stuck to the chest. Uh, Raynaud's present. There is like foot foot stucking problem. So yes, and bluish discoloration. This is Raynaud's. You know that. So SLE, systemic sclerosis, and there is some sort of muscle problem. Yes, muscle problem along with rheumatoid arthritis. The muscle problem is given here. In the stem, look which has the like in the option. Where is the muscle problem? In which yes, like muscle problem like weakness while you sit from while you stand from sitting position. Yes, that yes, I said muscle. So mixed connective tissue disease, there is lots of things are mixed. So that's why you need to find out. Anti-U1 RNP is classic for MCTT. So if you find anti-U1 RNP, that is enough for diagnosing MCTT. Even if you don't find the other things positive. Okay. MCTT is a chronic, MCTT is an autoimmune disorder characterized by variable clinical feature SLE, systemic sclerosis, polymyositis, rheumatoid arthritis. Uh, I usually I forget plenty of time, so I haven't find any mnemonic. CTD. Okay. Uh, mm, patients may initially have symptoms fever, fatigue. Patients may initially have systemic symptom fever, fatigue with more specific feature appearing sequentially over time. The most important diagnostic findings, the most important diagnostic manifestation include Raynaud phenomenon, swelling of the fingers and the hands, inflammatory arthritis, myositis. Patients may develop Patients may develop malar rash, discoid rash, plaques resembling SLE, but kidney and the CNS problem seizures are uncommon and generally mild. Pulmonary hypertension is the most common cause of death. Pulmonary hypertension is the most common cause of death. The most important serologic marker for MCTD is autoantibody U1RNP, which has high sensitivity, variable, level or other antibodies. Rheumatoid factor patients may be positive. Treatment includes systemic glucocorticoid and corticosteroid sparing agents. Methotrexate patients often have U1RNP associated with inflammatory arthritis. Raynaud's phenomenon is a feature of systemic sclerosis, sclerodactyly, esophageal dysmotility, as well as SLE malar rash. So therefore has a likelihood of developing polymyositis. Okay. If we want to differentiate from this to previous question like neuroma, how we can differentiate? It is phantom limb pain. I got it. I have found the answer. So how can we differentiate? You got my point. Phantom limb. Yes, I got it. Okay. So stump touching is the important. If we touch the stump and if there is pain, then it is neuroma. If in the stump there is non-tender, then it is for phantom limb pain, and phantom limb pain multimodal pain regimen, because patient feels pain where there is nothing. So neuroma, like I got it. What you are talking about, like hematoma. Okay, patient who required this patient who required mm, below knee amputation following trauma now has persistent pain in the absence of a portion of the limb. This presentation is most consistent with phantom limb pain and should prompt initiation of a multimodal regimen that includes for pharmacotherapy and adjuvant therapy. Phantom limb pain is a complex and incompletely understand pain syndrome that is extremely common, 50 to 85% among amputees. The pain which is perceived in the absent portion of the limb and is usually neuropathic, shooting, burning, and may have seemingly unrelated inoculous triggers. Urination definition: severe preoperative pain due to devastating devascularizing trauma, and postoperative pain likely increase the risk of developing phantom limb pain. Treatment of phantom limb pain is usually multimodal and may include pharmacotherapy, antidepressant, anti-epileptic, gabapentin, NMDA receptor antagonist, ketamine, analgesic, acetaminophen, opioid, adjuvant therapy, biofeedback, cognitive behavioral therapy, mirror therapy, using a mirror to watch a reflection of the resident limb moving at the location of the affected absent limb. Okay,
Knee pain.
okay. This patient with a chronic knee pain and a bland synovial effusion, no organism lesion, 2000, white blood cell per millimeter cube, has osteoarthritis, a progressive disorder that commonly affects the hands and weight-bearing joints. Major risk factor include obesity, advancing age, diabetes, prior joint injury. Most patients have pain with weight bearing and few associated with symptoms, although a subset can develop swelling, breast pain, brief morning stiffness. Patients show crepitus, periarticular bony enlargement, and painful decreased range of motion. X-ray finding include narrow joint space, osteophyte, and subchondral sclerosis or cysts. Synovial effusion are common in older patients with osteoarthritis. Communication of the joint space with the gastrocnemius and semimembranous allows the synovial fluid to flow posteriorly into the bursa, forming a popliteal or Baker's cyst. Effusions can also form in a variety of other arthritic conditions: rheumatoid arthritis, crystalline arthritis, knee injury. Arthrosynthesis can be used to distinguish the underlying etiology. Joint fluid cell counts in osteoarthritis are significantly lower than in RA with crystal-induced arthritis. Okay,
Yeah, without.
RA RA can cause popliteal cyst formation, but the synovial fluid in RA shows inflammatory effusion. In addition, uh, it typically uh, uh, it typically also involves the small non-weight bearing joints of the hands and is associated with systemic symptoms: fever, fatigue, prolonged or morning stooping more than 30 minutes, and synovitis. X-ray reveals periarticular osteopenia with erosion of the giant margin. Okay,
Mhm. 66. Fever and body ache.
is it septic arthritis, enteropathic arthritis, osteoarthritis, gout? Why it is gout? This patient with this patient with acute, rapidly progressing ankle pain and a prior history of similar pain has acute gout, although it is most common in the first metatarsophalangeal joint. Gout can also involve the knees and the ankles. Gout is characterized by recurrent attacks that typically develop overnight or early in the morning, reaching maximum intensity within 12 to 24 hours. Definitive diagnosis is obtained via definitive diagnosis. Uh, Definitive diagnosis is obtained via synovial fluid analysis showing inflammatory cells and needle-shaped negatively bifringent urate crystal. A gout attack can be precipitated by conditions that can cause increased production or decreased elimination of the uric acid or acute change in uric acid level. Common triggers include heavy alcohol consumption, intake of urate-rich products, trauma, surgery, dehydration, medication that raise thiazide cyclosporin or lower allopurinol uric acid level. Okay.
68-year-old man or severe patient
Okay. This patient's presentation is concerning for septic bursitis, the prepatellar bursa. The prepatellar bursa. The prepatellar bursa is a fluid-filled synovial sac. The prepatellar bursa is a fluid-free synovial sac that alleviates friction between the patella and the skin. Prepatellar bursa. Infection of the bursa can occur superficial abrasion from working while kneeling, presenting trauma, or extension of from cellulitis, gram-positive skin floors, Staph aureus account for most cases, and the risk is greater in patients with immunocompromising conditions. Diabetes mellitus septic bursitis is characterized by boggy swelling of the bursa associated with erythema, warmth, and pain. Fever is often present, more than 40% of the cases, but may be less prominent in patients aged more than 65. Aspiration of the bursal fluid can be performed to differentiate septic from sterile non-infectious bursitis. The fluid should be sent for cell count, gram stain culture, crystal analysis. Treatment includes systemic antibiotics. Drainage is indicated when the bursitis fails to improve after several days, 2 days of the antibiotic therapy. Okay. Yes. Knee joint rather than bursal fluid aspiration. Knee joint rather than bursal fluid aspiration is indicated for suspected septic arthritis, which is represented more diffuse versus localized prepatellar swelling and severely painful reduced range of motion. This patient has intact range of motion of the knee with little pain, indicating that the pathology is extraarticular. And knee D, which one? Okay, a knee compression wrap or a knee compression wrap and ice application are used to treat non-infectious bursitis due to overuse. Non-infectious bursitis is sometimes challenging to differentiating from septic bursitis. However, if features concerning for septic bursitis, erythema worm, aspiration of the bursal fluid should be performed to exclude the infection. Okay, okay. This is dermatomyositis. Dermatomyositis is an autoimmune condition that is twice common in women. In its most classic form, it causes proximal muscle inflammatory myositis and characteristic scabbiness finding biolaceous poikiloderma over various regions of the body. On the face, the eruption is accompanied by periorbital erythema, often with edema, is known as heliotrope sign. The erythematous rash shows a photo-distributed pattern on the chest, V sign and back, shawl sign, violaceous, especially scaly lesion can be flat Gottron sign or raised Gottron papule can be present on the metacarpophalangeal joint, proximal interphalangeal joint, elbow, and knees are the pathognomonic for dermatomyositis. Due to inflammatory nature of the dermatomyositis, patients may have elevated creatinine phosphokinase that is generally 10 times the upper limit of the normal but can vary. The classic autoantibodies associated with dermatomyositis is anti-amine against helicase, anti-Jo1, anti-synthetase antibody found more commonly in polymyositis. Malignancies are common. Malignancies are common in patients with dermatomyositis. The most common malignancy are adenocarcinoma, ovarian, lung, pancreatic, stomach, and colorectal. The pathophysiology is association. The pathophysiology, the association is unclear but may be related to cross-reactive and autoantigen in the muscles of the tumor cell. Regular age-appropriate cancer screening is essential, and other studies chest X-ray. Gynecological evaluation are often considered an initial diagnosis for further investigation of underlying malignancy. Okay, have you done your breakfast? Okay, you have your breakfast, then we continue the rest of the block.